I'm honored to introduce our next speaker, Wayne Yu from the Department of Pathology and Laboratory Medicine at Memorial Sloan Kettering Cancer Center. Wayne will be presenting on the implementation of NGS-based clonality and MRD testing in a high-throughput environment. Wayne has been a clinical laboratory technologist for 13 years. Initially, he started his career in clinical microbiology. For the past 9 years, he has been working at the Diagnostic Molecular Pathology Department at Memorial Sloan Kettering Cancer Center. He's a team lead technologist with the LymphoTrack assay and assisted with implementing the assay in the laboratory since 2016.
Good morning. Thank you for the introduction. These are my disclaimers. Today, I'm going to discuss the workflow overview of the LymphoTrack MySeq assay at Memorial Sloan Kettering Cancer Center based on the perspective of a laboratory technologist such as myself. I'm going to describe two different types of sample testing. One is characterization, and this involves testing baseline samples with adequate tumor content at about greater than equal to 2 to 5% abnormal lympho cells, based on ancillary studies such as flow cytometry, morphology, and immunohistochemistry. We also test for IgH3 somatic hypermutation, and we determine the mutation rate by comparing the clonotype sequence to a reference gene, and this aids in prognosis for chronic lymphocytic leukemia or small lymphocytic lymphoma, or in mantle cell lymphoma or hairy cell leukemia. The other type of testing is called monitoring, and this is testing any follow-up samples after characterization. And another test is for measurable residual disease testing, or MRD testing. Before discussing the LymphoTrack assay, I'd like to briefly discuss the PCR-based Clonality assay for ABI fluorescence detection designed by Biomed2, which has standardized guidelines for interpreting and reporting results. It has been the gold standard method for the past 2 decades, and is the multiplex PCR-based assay for IgH and TCR gene rearrangement, and the primers are conjugated for fluorescent dyes and analyzed by capillary electrophoresis. It has about approximately 5% sensitivity based on a clonal population of at least 5%. The assay used is to test baseline samples for rapid turnaround time. The LymphoTrack NGS assay on MySeq is also a multiplex PCR-based assay for Ig and TCR gene rearrangement, and the primers are attached with Illumina adapters and indexing barcodes. This allows for a one-step PCR and a pooling of multiple samples and targets in the same sequencing run. It can provide the DNA sequences with VJ gene names specific for each clonal rearrangement as a percentage of total sequencing reads. It can characterize an initial baseline sample and can track subsequent samples at a sensitivity of 10 to the -5 based on our experience at MSK. Here are the primers that we use routinely. There are forward and reverse primer sets that target the conserved regions within the variable and joining regions. For IgH, there are primer sets targeting the framework region 1, 2, and 3, in addition to a leader primer set that targets upstream of the framework region 1. This allows sequencing of the entire IgHV region and allows assessment for somatic hypermutation. This is the workflow for in the IgH LymphoTrack studies at MSK. Initially, the samples are reviewed for case history and ancillary studies. Then it gets extracted for its DNA and stratified into either characterization or monitoring. For characterization, when we test for IgH3 somatic hypermutation, we test the leader primer up front and then FR1 primer if necessary. For other types of malignancies, we screen the samples by capillary electrophoresis with framework 1, 2, and 3 primer sets. If confirmed clonally rearranged, we reflex the LymphoTrack with 250 nanograms DNA using appropriate primers based on the pattern of the capillary electrophoresis graphs. For monitoring, if a baseline sample is not characterized previously, we will retrieve the archived sample with adequate tumor content for testing first prior to testing the monitoring. For MRD testing, we test for primers detected from a characterized sample with 700 nanograms each and duplicate, with the second replicate spiked in with a lymphoquant. The workflow for TRG LymphoTrack studies is similar to the IgH LymphoTrack studies. When characterizing, we screen the baseline sample with capillary electrophoresis using the TCR primer set. And when it confirmed clonally arranged with the TCR gamma primer, we test the LymphoTrack using the TRG primer. And for monitoring, We also retrieve archived samples with adequate tumor content for testing if the baseline sample has not been characterized previously. And for MRD testing, we test 700 nanograms each in duplicate. The types of samples that we test are EDTA, peripheral blood, and bone marrow, which we usually use 300 to 350 microliters of heme sample to extract. Other types of samples include FFPE, fine needle aspirates, and sorted flow cytometry cells, and fresh tissue. The ideal minimum DNA concentration is greater than or equal to 30 nanograms per microliter at about 100 microliter elution volume. If the blood or bone marrow is less than 30 nanograms per microliter, we automatically extract the buffy coat by spinning down the heme sample in an attempt to concentrate the white blood cells. For characterization, we use optimally 250 nanograms per primer target. If there is very scant material, a minimum of 50 nanograms of high quality or high tumor proportion DNA may work. When testing with MRD samples, we test 700 nanograms in duplicate for a total of 1,400 nanograms. When testing FFPE, their DNA quality is usually fragmented, so consider using primer targets that amplify smaller fragment sizes, especially if your DNA is limited. If the DNA concentration is not met initially, DNA can be concentrated with a SPEVAC vacuum concentrator, and this evaporates the solution that the DNA is suspended in. The next few slides are a technical step-by-step procedure for the workflow. For setting up a run with samples, as discussed before, we check for previous testing and ancillary studies. We determine appropriate test type and primer type. Up to 24 indices are used per run for a total of 24 reactions, where one index is used per reaction. The run can include either or both the characterization, where one reaction is used per primer, and for MRD testing, 2 replicates are tested with different indices. The second replicate is spiked in with the lymphoquant. Then you assign indices to samples that have not been used before for the test subject to prevent crossover contamination between runs. You avoid testing more than one sample from the same test subject in the same run to prevent barcode hopping. Then you can include positive control, a negative control, and MRD low positive control with a sequence that can be detectable at 10 to the negative 4. For routine PCR setup, up to 10 microliter maximum volume of sample DNA can be input into the reaction. But when you're setting up an MRD sample or a low positive control with lymphoquant, you always put 2 microliters of lymphoquant in the reaction while using a maximum volume 8 microliters for the sample DNA. When setting up run with leader primer, the thermocycling conditions are different from all other target primers. It has 3 extra cycles in the thermocycling PCR program. After PCR, the amplicons are purified with Ampere XP bead-based reagent. All steps here are automated by a liquid handler. The amplicons are quantified by qPCR based on a standard curve generated by 6 pre-diluted standards. And the primers are targeting the Illumina adapters. The average base pair price is average base pair price of the fragments are determined by automatic electrophoresis. When we pool libraries separately by primer type at 4 nanomolars. If the samples with less than 4 nanomolars, we aliquot the maximum volume possible. After pooling, the pools are quantified by another round of qPCR and automated electrophoresis. When sequencing, the final denature library is 12 to 20 picomoles as long as the sodium hydroxide concentration is less than equal to 1 millimolar. When sequencing with primers except leader, we use a 500 cycle MySeq reagent kit, and the sequencing runtime can take approximately 39 hours. When sequencing with leader, we use a 600 cycle MySeq reagent kit, and it takes approximately 56 hours to sequence. For sequencing metrics, we look for greater than 80% cluster passing filter, and the quality Q30 score, we look for greater than 75% for a 500 cycle kit, and greater than 70% for a 600 cycle kit. After each sequencing run, we perform 2 post-run washes to prevent crossover contamination between runs. The first wash is called the template line wash, and it includes 0.01% sodium hypochlorite and 0.5% tween 20 solution. The second post-wash is a 0.5% tween 20 solution. We also implemented a system where, in order to reuse the same MySeq, 2 non-lymphotract runs with different types of indexing barcodes are ran on the same MySeq before we can reuse it again. For analysis, the MySeq FASTQs are analyzed, and the output files generated from the LymphoTrack MySeq and MRD software are uploaded to our centralized sign-up portal, which was built in-house. It can review results and generate template reports. It can save characterized sequences for future monitoring. And as a QC check, we can confirm unique sequences between samples. Other tools that we can use for analysis is IGBLAST or IMGT to analyze sequences in detail, and a sequence alignment to compare sequences manually. This is a busy table for clonality criteria at MSK. The criteria is based on the total number of reads of the sample and the number of dominant sequences and their detection frequencies. Basically, the more reads, the better. There are two categories for successful characterization. The first category is optimal results, where the total reads are greater than 100,000. In some cases, greater than 50,000 is okay. To make a clonality call, the dominant sequences have to be greater than 2.5% of the total reads and greater than 10 times the polyclonal background. In the second category, the qualified results are between 30 to 50,000 reads. Here, more sufficient stringent criteria needs to be called for clonality. Here, if the dominant sequence have to be greater than 5% of the total reads and greater than 20 times the polyclonal background. In this category, more primers may be needed to be tested to confirm the clone. The next few slides are cases of characterization cases that I have encountered. For case 1, a blood sample was received and the flow cytometry shows abnormal B cells representing 50.5% of the total white blood cells, indicative of CLL, SLL. When we tested with LEADER, it detected a single clonal rearrangement sequence. However, the sequence is unproductive. When we tested for FR1, it showed a bioallelic rearrangement. It detected the same sequence, same unproductive sequence that was detected by LEADER, in addition to a productive sequence. So the two clonal types by FR1 are resulted. However, the IGH3 mutation status is only determined by the productive rearrangement. Since the mutation frequency is 0%, the IGH3 mutation status is unmutated. According to the European Research Initiative on CLL guidelines, a mutation rate of less than or equal to 2% is considered unmutated with an unfavorable prognosis. Greater than 2% is mutated with a favorable prognosis. 2.1% to 3% is considered borderline mutated. Clonal type with a 3-21 stereotype subset number 2 in CLL is considered to be an adverse prognosis independent of the IGH3 mutation status. Case 2 shows a IGH characterization of a bone marrow where the flow cytometry detected abnormal plasma cells representing 5.9% of the white blood cells, indicative of multiple myeloma. If you look at the capillary electrophoresis graphs, only FR2 showed a distinct clonal peak, while FR1, FR3 showed a prominent peak. When we tested for FR1 LymphoTrack, it shows a polyclonal pattern. But when we tested for FR2 in the leader, it detected confirms the same clonal rearranged sequence. This is an example where this has primers can have poor primer annealing, and multiple primers need to be set up front to confirm a true clone. The third case is a blood with a flow cytometry that shows 59% abnormal B cells, indicative of CLL, SLL. When we test for leader in FR1, and after merging, all the sequences have the same VJ gene name, and the frequencies are distributed due to ongoing somatic hypermutation. This is a case where it will be complex for monitoring for future MRD testing, and the level of detection can be underestimated. A less stringent MRD search for these sequences requires analyzing multiple sequences. Case 4 is a bone marrow biopsy, which shows 74% abnormal B cell lymphoblasts by flow cytometry, and it's indicative of B lymphoblastic leukemia or lymphoma. The capillary electrophoresis graphs show no clonal rearrangement by FR1, FR2, FR3 primers. However, when you test it for the TCR gamma version 2.0, we showed a distinct clonal peak. This is confirmed by the TRG LymphoTrack, where two clonal rearranged sequences are detected with the same base pair size. This example is of a cross lineage which can occur for BAL cases. When selecting targets for follow-up MRD, you choose the primer target that meets the criteria for clonal rearrangement with clear dominant sequences and optimal reads. If the multiple primers are tested, you compare the total percent reads for the detected rearranged clone from each primer. Usually, the primer with the highest total percent reads is selected. You can also compare the amplicon concentrations for the primers tested in the sample to see if it's greater than 4 nanomolars. If different primers detect different dominant clones, you can assess for amplification bias. In rare occasions, you may need to test for greater than 1 primer for MRD testing. If IGH and TCR were clonally rearranged, both may need to be tested for MRD depending on the context. You can correlate ancillary studies with total read frequency of the clonal type tested by a specific primer. For example, if flow cytometry indicated high level of malignancy, but borderline or low frequency detection of a clonal rearrangement, you have to test with multiple primers to confirm the clone. For IGH, you can check if the clonal sequence has adequate V coverage to rule out any artifacts. Here's the monitoring criteria for MSK. Generally, greater than 50,000 total reads is considered acceptable. With greater than 200,000 total reads is optimal. Recount for less than 50,000 is considered to be a failure, but a low recount may indicate MRD negativity. Both replicates should have concordant results, detected or not detected. Testing is repeated if there's a discrepancy between the two replicates, 1 out of the 2 detected. If the characterized sequence is detected in greater than 2 out of the 4 replicates, you can report detected. Here are the 2 types of MRD calculations made. The first type is the percent total reads of the clonal type out of the total reads of the sample for both replicates. Since the total reads of the sample is representative of total rearranged reads of the lymphoid cells and not lymphoid cells that are in germline configuration, normalization is needed to assess the overall disease level. And using that lymphoquant internal control can be used as a spiking calibrator to calculate for that percent normalized disease level. These calculations can be automated with the current version of the LymphoTrack MRD software. So the lymphoquant B-cell internal control is a spiking calibrator consisting of a cell line-derived DNA with a single rearrangement of IGHV1-69J6 gene. Since a human cell has an average of 6.5 picograms of DNA, during PCR setup, 2 microliters of lymphoquant, which is equivalent to 100 cells, is spiked into 700 nanograms of sample DNA, which is equivalent to 100,000 cells. Here in method 1, this is one way of calculating percent normalized disease level, and it composes of 2 steps. The first step is calculating for the estimated clonal cell equivalency. And this is a ratio of the read frequency between the clonal type sequence and the lymphoquant times 100 cells. Once you determine the number of cells, you can calculate that percent number of cells out of the 100,000 cells you inputted in the PCR. The second method is to calculate the normalized disease level directly, and this is basically a combination of the 2 steps above in method 1. The formula to determine it is the ratio of the read frequency of the clonal type sequence and the lymphoquant multiplied by 0.1. Case 5 is a IHH monitoring case. We initially characterized a bone marrow for leader IHV. 3 months later, we collected another bone marrow for monitoring, and the flow cytometry showed 1.1% abnormal B-cell population of the white blood cells, consistent with previously characterized CLL. 2 replicates are tested, and the characterization sequence is detected approximately between 37 to 39% of the total percent total reads. In the separate replicate, the lymphoquant is detected at about 3% of the total reads. The table shown is a MRD output table that for the baseline sequence and the lymphoquant sequence. It shows you the total number of reads for the replicate, and also the amount of reads and the frequency detected at exact match, 1 mismatch, and 2 mismatches. When you calculate for the percent total reads, it comes out to be 38.54%. But when you calculate for the percent normalized disease level, it comes out to be 1.16%, which is concordant with the 1.1% abnormal B-cell population detected by flow cytometry. For more details on MRD testing and the lymphoquant in B-cell and plasma cell neoplasm, an article was published this year in the Journal of Molecular Diagnostics by a cohort led by Dr. Maria Arcilla and Dr. Ying Liu. For future considerations for especially testing in a high throughput environment, implement automation as much as possible, whether it be in the wet lab or an automated analysis to improve turnaround time. More indices can increase flexibility in testing on top of what is available for purchase. And In Vivo Scribe is working on a solution to implement these benefits. And then further studies are required to establish standardized guidelines for NGS clonality and MRD testing. Thank you. Any questions?
Thank you very much for the nice talk. Falco Fenn from TU in Germany. First, a small comment. So Clonality is working on standardized guidelines for MRD testing as well as establishing clonality with NGS. And I have a brief question. Sometimes occasionally we only encounter kappa rearrangements when we are testing B-cell neoplasms. And you showed nicely how to assemble the clone despite somatic hypermutation for heavy chain genes, which is not a problem. But for kappa genes, this is a little bit more complex because the diversity of kappa is a lot lower. Right. And so to assemble, to really put together what belongs to the clone, to the true clone with somatic hypermutation, and what are related clones is more difficult. Do you have any specialized pipelines to look at kappa rearrangements?
We have tested kappa before, but we haven't generated enough experience on it. It has a propensity for multiple rearrangements, which is complex for MRD testing. So more testing is needed to standardize guidelines. Yeah.
Hi, just a small practical question.
Yep.
So what would be the turnaround time from sample receipt to actual analysis and receipt of results?
Generally, since sequencing, it takes about 2 to 3 days. All right, it could be about 2 days of wet lab and probably 1 day of analysis. It could take about a week, actually. Yeah.
And do you find that quicker, than the fragment analysis pathway?
Oh, for fragment analysis, you can determine the clonal rearrangement quickly. Most of the time, usually fragment analysis is to confirm the clonal rearrangement at a faster turnaround time. A lot of the times, you can compare like a heme sample to an FFPE sample to confirm the same clone. Yeah.
Thank you.
Yeah.
I'm assuming that the capillary PCR is different primers than the next-gen sequencing PCR. So how often do you see a mismatch between a positive result on framework 1, 2, and 3 by capillary compared to the next-gen sequencing? Say you were expecting to see a positive framework 1, which you saw by capillary, but you did not see a positive framework 1 by next-gen sequencing.
Yeah. It could happen. The primers are similar, but not exactly the same. So we test initially, let's say by FR1, and if it doesn't work, we sequentially reflex to other primers. Yeah.
That's a lot of work and time, especially if you want to get something out quickly. Could you comment on which framework is most often concordant between capillary and next-gen sequencing?
Sometimes we can try with FR1, but then when you can try, there are times where you can try leader to confirm the clone. It works a lot of the times. And leader, since it has the largest fragment size, so it can provide the most information as well. Yeah, we usually use FR2 and FR3 as a backup to produce smaller fragment sizes.